it's time to put together whatever you have learned in the past year to some good use in terms of your NEET PG exam. Now, ophthalmology is actually considered a minor subject by many, but you must remember most of the questions in ophthalmology make or break the result. So it's time to have a catch up of whatever we have learned in the past year. So what I have done is I have divided the questions that come in your exam in subsections. So the first subsection that we would be taking up is conjunctiva and cornea. I'll also be telling you the high yield topics which generate questions from this subsection so that you can focus on it in a better manner. Now, some slides you may find crowded, but my emphasis has been to provide you with maximum information so that you can go back to the slides and read whatever we have missed out while I'm addressing this topic. So let's start. The high yield topics for conjunctiva basically talk about conjunctivitis, adenoviral conjunctivitis and vernal keratoconjunctivitis being the most common entities, pterygium and dry eyes being the next. Amongst cornea, we do get questions related to multiple types of characteristic features of keratitis, but out of that, we have seen that in the past few years, there have been quite a few questions on Murray's ulcer, which is a type of peripheral ulcerative keratitis, keratoconus, and different forms of keratoplasty. So first, I'll be covering the questions that have been asked in the previous exams, and side by side, I'll be giving you related information that can come in handy if questions related to this particular topic come. So let's set the wheels in motion. The first question for this section, which has been asked in a previous exam, includes different options which want you to recognize this pathology. They have given us a picture, and there is, as you can see, a nodular lesion in this picture at the limbus margin. So the options are pterygium, Pinguicula, Limbal dermoid, or a lipodermoid. Let's have a look. Now, when we talk of lipodermoid, we are having two components, one being lipid and the other being dermoid. Now, we all know the characteristics of dermoid, that it has contents like hair, different type of glandular structures, and sometimes even teeth. Lipo means fat. So this dermoid has a fatty component to it as well. Now, it is usually seen as an abnormal epibulbar growth of adipose tissue present at either the lateral canthus or the limbus. Soft because it's fatty, yellowish again because it's fatty, and it's a subconjunctival mass. So the conjunctiva overlying this mass is not freely mobile. So it's strictly adherent to that mass. And there is a dermal fatty tissue related to this. In order for you to differentiate with certain other pathologies, because it's not necessary that in your coming exam you get a picture of lipodermoid, you may get a picture of a dermoid, a pterygium, or pinguicula. I'm showing you these three entities. So here we have a hair coming out from a dermoid. This is a wing-shaped lesion, that is pterygium. And here we have a small nodular yellow cystic lesion in the bulbar conjunctiva, but well away from the limbus, and this is pinguicula. So keep a note of all these pictures, because what your mind knows has come from what it has seen. So these pictures will come in handy in case you have any similar question. Now, it's very important to know that there are several systemic entities that are associated with dermoid choriostomas, the most common being the Goldenhar Syndrome, and there are many questions that come related to Goldenhar Syndrome. Then we have nevus flammeus and neurofibromatosis. Look at Goldenhar Syndrome patient. Most common thing that you will find in your question is a preauricular tag, a skin tag just in front of the auricle, other skin tags, and a dermoid. So if you have a clinical scenario in which you have a patient with dermoid or a limbal dermoid with tags right in front of the skin or on the neck with certain associated abnormalities, systemic abnormalities, then the answer would point towards Goldenhar Syndrome. These patients also have squint, they have Duone's retraction syndrome, they may have microphthalmia, and epibulbar dermoids are seen in nearly 1/3 of cases. Infratemporal quadrant of the limbus is the most common area where you will find a dermoid in such patients. These patients can also have eyelid or iris colobomas, and the eyelid colobomas are common in upper lid. So I have given you several scenarios which can fit into the Goldenhar syndrome, and this can also come as an MCQ question by itself. There are certain other features of Goldenhar syndrome. Now, since it involves other areas of the body, this question can actually come as a systemic abnormality. So even as an ENT issue, you can also have this question. So in ear, the patients will have mildly dysformic ears. They'll have anosia. They may have supernumerary ear tags or preauricular tags, as I've already talked about. There is facial asymmetry with unilateral macrostomia. There is hypoplasia of mandibular ramus. Now, if you look at this part, you will see one side of the mandible is hypoplastic. There can be cranium bifida, microcephaly, dolichocephaly, and plagiocephaly. These patients may also have spina bifida, and they may have hypoplastic vertebrae. They can be fused together. This syndrome can also involve abnormalities of trachea, lung, heart, kidney, and even GIT. So you see, it's a multi-system deformality, and if you have any of these systemic abnormalities in conjunction with a dermoid and preauricular tag, the answer is Goldenhar syndrome. So coming back to our question, looking at this image, very well circumscribed yellow lesion at the limbus at the inferior or maybe infratemporal part is lipodermoid. Coming to question number 2. This also has been asked in a previous year, and they also gave a clinical picture. Which of the following is not a feature of pterygium? First option is elastotic degeneration of stromal collagen. Second, pterygium has 3 parts: head, neck, and body. Third, simple excision reduces 95% recurrence, and progressive and regressive are 2 types of pterygium. Now, which is not a feature of pterygium? Always, whenever you are reading a question, please focus on elements like not, except, and all. So pterygium is actually coming from a Greek word which is pterygion, and it means a wing. Nasal pterygium are more common than temporal, and if we have pterygia on both sides, nasal and temporal, which are meeting each other, it is called as a kissing pterygium. Pterygia are more common in males as compared to females. Basically, what is happening is elastotic or basophilic degeneration of the conjunctiva due to exposure to harsh sunlight and windy environment, and UVB rays are the culprit in this scenario. It's quite commonly seen in countries which are closer to the equator or in tropical countries like India. And people who work in sunlight or who are more exposed to the UV light are more likely to get it. So farmers, laborers, people who drive a lot during the day, they are more exposed to these harsh radiations, are likely to have it. It's also known as the surfer's eye because in countries like Australia, people are surfing and they're closer to the equator. So the direct rays of sunlight, they can damage the conjunctiva and eventually lead to pterygium formation. Now, as long as it is not encroaching the visual axis, it is not covering the pupil, you can let it be. It's basically a cosmetic disfigurement, and as long as it is not disturbing the vision, it's fine. You can give lubricants in the form of artificial tears to make the surface smooth and patient asymptomatic, but there's no need to surgically intervene. So when do we decide that this patient needs surgery? First being encroachment of visual axis. So it is coming closer to the pupil. As you can see in this patient, the pupil is almost bisected because of the pterygium. Second is that this entire bit of pterygium is causing a significant amount of astigmatism and refractive error, which is quite disturbing to the patient and therefore requires a surgical intervention. And third, if the patient has cosmetic concerns, so then also it requires a surgical intervention. So here we have a kissing pterygium, nasal and temporal pterygia coming together, and this lower image shows the basophilic degeneration. So you can have either of these images in your paper and you can figure out which option suits the best. It's also important to differentiate between pterygium, which is a true pterygium, and pseudopterygium. Now, pterygium actually is a degenerative process, and pseudopterygium, on the other hand, is an inflammatory process. Pterygium occurs in elderly individuals, while pseudopterygium can occur in any age where there is excessive inflammation in the conjunctival and corneal area. The site, as we have talked about, for pterygium is either nasal or temporal, so therefore 3 or 9 o'clock, while pseudopterygium can occur anywhere in the bulbar conjunctiva. Pterygia are usually bilateral, while since it is the inflammatory pathology, pseudopterygia is usually unilateral. Pterygium can be stationary, progressive, or regressive, while pseudopterygium, fortunately, is stationary. The probe test is quite an important feature and can come as an option in your MCQ question. The probe can pass through the pseudopterygium underneath it because this is a loose inflammatory tissue. The glass rod can be easily pushed through underneath the pseudopterygium, while it is not possible to pass it through the pterygium because pterygium is very strongly adherent to the sclera. And if you attempt to peel off the pterygium, it's likely to bleed because of its strong adhesion, which is not the case with pseudopterygium. Also, another thing is that you see a line which is called as the Stalker's line, where the pterygium is attached on the cornea. Now, this is because of iron deposition, and you can have a question: in which scenarios do you see a Stalker's line? So the answer would be pterygium. So you see, from one question we have diversified into 2-3 questions that can come, and it's important to remember these basic findings related to this entity. It's also important to know the stage of the pterygium so that you can explain to your patient whether they require a surgery urgently or they can wait for some time. In stage 1, there is minimum invasion of the cornea because the pterygium is still like a thin translucent growth and there are thin blood vessels on it. So there is no fleshy mass which is, obscuring the pupillary axis, so patient can easily wait. In stage 2, there is a moderately thick pannus. Now, pannus is nothing but a leash of blood vessels. The deeper vessels are not visible and there is a significant invasion of cornea. Now, this is the time when the patient can be undertaken for pterygium excision. While in stage 3, this growth becomes quite thick, quite fleshy, and it covers the pupil with dense vascularization. And in such cases, you require a significant amount of dissection to remove this pterygium. And sometimes we have to be prepared with a corneal graft because removing it from the cornea may result in thinning of the cornea. So you have to be well prepared in stage 3 with the corneal graft. So the answer here is simple excision reduces 95 recurrence. Why? Because if you just remove the pterygium, it's going to come back again. You got to treat the area on which the pterygium was adherent so that it doesn't recur. So how do we treat it? We treat it using an anti-metabolite, which is mitomycin C. So you remove the pterygium, you treat the scleral bed with mitomycin C. After that, you put patient's own conjunctiva, which is called as a conjunctival autograft, on the bare sclera and either suture it or use fibrin glue to make it adhere to that sclera so that there is no recurrence. Despite using mitomycin C and a conjunctival autograft, still there can be recurrence. So you cannot be sure 100% that this will not recur. So if you just leave it like that without any adjunctive therapy, the chances of recurrence are very, very high. Therefore, our answer is answer C, that simple excision reduces 95 recurrence, because this is false. Let's move on to the next question. Again, we had an image. Again, you know that this wing-shaped thing is nothing but a pterygium. So, visual disturbance in the following picture is due to answer A, lesion occluding the pupil, option B, astigmatism, cataract, or myopia. Now, we know that this is occluding the pupil and there is only a crescentic amount of pupil which is left. But look at the amount of cornea that this is covering. That's quite significant. So essentially, it is leading to a lot of astigmatic error. So before we go on to the correct answer, let's have a look at some more pterygium facts so that we are able to address any question that comes related to pterygium in any permutation or combination. So pterygium increases with the rule corneal astigmatism and corneal irregularity. It induces a lot of higher order aberrations. The induced corneal irregularity, the values are associated with the area of pterygium. So let's go back and see that there is so much of area of cornea that is being occupied with this pterygium. So this is going to induce a lot of corneal irregularity, and this irregularity will translate into a variable form of astigmatic error. The length of the pterygium is an independent inducer of the oblique trefoil or quatrefoil. Now, trefoil or quatrefoil are types of higher order aberrations, and so longer the pterygium, more the higher order aberrations, more the visual disturbance. The greater thickness is linked to increased risk of recurrence. Now, we talked about stage 2 and stage 3 in our previous example. So, if you allow the patient to wait from stage 2 and to go on to progress to stage 3, we need to tell them that if you wait longer, the likelihood of pterygium recurring is going to increase. So, it's better that you get operated during stage 2. So, it helps you to prognosticate and tell them the outcome. Now, pterygium with a flatter corneal scleral transition zone induces more corneal scarring and astigmatism than pterygium with a nodular appearance and traction by body or tail, which is evoked by the temporal gaze. Now, what do we mean by that? If you look at the top picture, this is quite adherent and flat. So, the amount of dissection that would be needed to do is getting very close to the corneal tissue. So, if we are closer to the corneal tissue, we are likely to induce more changes and to have more chances of recurrence, unlike something which is nodular and fleshy and can be just lifted up and shaved off from the scleral bed using a crescent knife. So, although on the face value of it, it will appear that, a flatter pterygium is a good one, but the nodular one in stage 2 or something which is a little bit more fleshy gives you a better outcome post-surgery. So, the answer for our question was that the visual disturbance in our patient is because of astigmatism, because of the facts that I have just told you. Also, remember that pterygia that are more than 3 millimeters in length can cause topographical distortion. Now, the corneal surface has a certain topography. It's different in the center and it's different in the periphery. It's different anteriorly and it's different posteriorly. So, since the pterygium is attaching nasally, it is causing a change in the nasal topography, and this topographic map has been obtained using an instrument called as pentacam. Now, since it is attaching to the nasal side, keratometry, which is just doing K1 and K2 values, basically this quadrant and this quadrant, is not going to give you the entire information. So, to have the entire information, you need to have a corneal topography. So, remember, corneal topography gives you more reliable information as compared to keratometry for patients with pterygium, and any pterygium which is more than 3 millimeters in length is going to cause topographical distortion. So it's a good idea to get a pentacam done for such patients. Coming to the next question. Which layer of cornea helps in hydration of stroma of the cornea? Now, how many layers of cornea do we have? Please don't answer 5. Now we have 6 layers. Dua's layer being the 6th layer that has been added to the corneal layers. So the options that we have for this include endothelium, epithelium, descemet membrane and stroma. So let's look at some facts so that we are better informed and give a better answer. So we have a normal cornea in which we have epithelium and then we have endothelium. Now these 2 layers which are forming the boundaries of the cornea are basically going to decide whether the stroma is going to get filled up with water or there is going to be an efflux of water. We don't want it to be dehydrated. We don't want it to be edematous. Now, the epithelium is actually exposed to the ambient atmospheric air, which will lead to evaporation of the tear film. And this evaporation is what actually keeps it from getting edematous most of the times. Remember, there are 2 different pressures which decide the intraocular pressure. One is the imbibition pressure, which is in the stroma because of the glucosaminoglycans, and the other is the stromal pressure per se. Now, both these will contribute to the intraocular pressure. The normal stromal pressure is 55 millimeters of mercury, and we don't want any change in the dynamics between the normal stromal pressure and the normal intraocular pressure. We get a swollen cornea if something goes wrong in the endothelium, that the pump mechanism starts failing, or if there is something wrong in the epithelium. Now, the changes have to be significant in the epithelium, while any subtle change because of a chronic problem in the endothelium can lead to stromal edema. When the intraocular pressure becomes more than the stromal pressure, epithelial edema will occur. So we have 2 scenarios. One, high intraocular pressure plus normal stromal pressure. Like we see in acute angle closure glaucoma. So there we see epithelial edema or something which is called as epithelial bedewing. And because of that, the patient has colored halos. Or we can have another scenario where the intraocular pressure is normal, but the stromal pressure is low. So eventually this equation will come out to be the same. And this usually is seen in Fuchs corneal endothelial dystrophy. So you have to recognize what is the change that is happening in intraocular pressure, the associated comorbidities, and figure out the exact pathology that is leading to the corneal edema. Another thing to remember that the endothelial permeability decreases once the endothelial cell count reduces to less than 2000 cells per millimeter square. Still, even after reducing to less than 2000, the metabolic pump mechanism will keep on working. It will keep on trying to save the cornea from becoming edematous. And this can go on only up till cell count of 500 cells per millimeter square. It's just like the gates of the Titanic. You close the lower gates and you're still trying to save the people in the upper areas. So the metabolic pump mechanism is those lower gates. So as long as you have 2000 up until 500 cells per millimeter square, the cornea will try to fight against getting edematous. So here our answer is endothelium. It is the endothelium which is protecting the cornea from getting very, very edematous. Another thing to remember, the interepithelial connections are zonula occludens, which are very strongly adherent to each other, unlike interendothelial connections, which are macula occludens and are not as tightly adherent. Therefore, epithelium is a little resistant to develop edema, unlike endothelium. Time for some more corneal facts. Let's have a look at some more corneal facts which can add on to your information profile if it comes to another question on cornea. the total refractive power of the cornea is 43 diopters. Now that contributes to 3/4 of the total refractive power of the eye. Remember that the cornea is quite steep at birth, it's about 53 diopters, and it becomes flatter with age, reaching about 43 diopters by 2 years. So beyond that, it's almost quite similar to an adult cornea. You also need to know the refractive index of cornea, which is 1.376. The thickness of the cornea in the center is quite different from what it is at periphery. The central corneal thickness is about 520 microns and the peripheral corneal thickness is nearly 670 microns. So the periphery is quite thick as compared to the center. Now the relevance of central corneal thickness comes in terms of measuring intraocular pressure. Thin corneas, they are more likely to be compressed when we take an intraocular pressure using an applanation tonometer, unlike thick corneas for which you will require an extra amount of pressure to figure out what is the exact value of intraocular pressure for that patient. So thin corneas can actually give you a fallaciously low value, while thick corneas can give you a fallaciously high value of intraocular pressure. Dimensions are very important because they can be a simple question in the form of dimensions for cornea or for any other intraocular structure. So when we talk of corneal size, the horizontal diameter at birth is about 10 millimeters, which reaches the adult size of about 11.7 to 12 millimeters by 2 years. So remember, by 2 years, the keratometry is also reaching the adult size, and by 2 years, the size is also reaching the adult size. We call a patient having a microcornea when the corneal diameter, horizontal, is less than 10 millimeters. And microcornea is usually associated with entities like congenital rubella syndrome and also choroidal coloboma. Megalocornea, mega, that means the cornea is large. So it's more than 12 millimeters at birth and more than 13 millimeters after 2 years. Now, megalocornea is associated with Marfan syndrome, Ehlers-Danlos syndrome, Alport syndrome, and Down syndrome. So you can get a question on the cutoff size for microcornea, the cutoff size for megalocornea, and the entities which are associated with this. So now the next question. There is again an image which has been given to you. You have to identify the stain with the light as shown. Now you are seeing a blue light and you are seeing this branching pattern with green color on the surface of the cornea. So this is a very typical dendritic pattern of herpetic keratitis, and this blue light is the cobalt blue light which we have on our slit lamps, and this green color is because of fluorescein dye which is being seen through this blue light. So what are our options? Fluorescein dye with cobalt filter, blue dye and green staining, Lissamine green and cobalt blue filter, and Lissamine stain. Now, as I have already told you that the dye that we are using to stain is a fluorescein dye, and that appears green when it is visualized through the blue filter. The answer clearly is A. But let's look at certain other vital stains that are used to stain the conjunctiva and the cornea. We have sodium fluorescein, the one we talked about, rose bengal, and Lissamine green. Now, Lissamine green has a very characteristic feature of staining the conjunctiva, and it gives us quite significant clinical clues to the health of the conjunctival tissue. Lissamine green needs to be visualized under white light and low illumination, as you can see here. So this area has been stained green because of this Lissamine green. Rose bengal, as the name suggests, roses are red, is red in color. It is visualized under white light and high illumination. But the drawback with this dye is that it really stings the patient a lot. So you have to put a local anesthetic agent before using this dye, and usually it is used after instillation of topical proparacaine eye drops to stain the conjunctiva. These are some characteristic features of these three dyes. For visualizing rose bengal and fluorescein, we need to use high magnification, unlike Lissamine green. The ocular irritation is most with rose bengal. The intrinsic toxicity, phototoxicity, is also quite significant with rose bengal. But one good feature of rose Bengal is that it has been shown to have antiviral activity. So it inhibits the activity of herpes simplex virus 1. It stains healthy tissues, damaged cells, dead cells, and mucous strands. So rose Bengal will actually stain a lot of tissue load, and the mechanism is that there is an insufficient protection by preauricular tear film, and that is what it promotes the staining by rose Bengal, and the staining is blocked by mucin. So essentially you need to remember these certain parameters about rose Bengal, because these are the parameters that differentiate it significantly from Fluorescein and Lissamine Green. You can also have the same scenario using a yellow filter. So this is a cobalt blue filter on top of which a yellow filter has been put, and you can see that here the image that you will see is green and green. So if you have two greens, it is cobalt blue filter with yellow filter, and if it is just blue, then it is cobalt blue filter without the yellow filter using the Fluorescein dye. Now remember that the Fluorescein takes a small wavelength of light and emits a larger wavelength of light. Remember your Vibgyor and you will be able to answer this question in a better manner. Going on to the next question. There is a brown ring around the cornea in the perilimbal area. What would be your investigation of choice for such a patient? Now, we usually get a lot of referrals from our physician colleagues who refer a patient just to rule out this brown ring, which is called as the Kayser-Fleischer ring. Now, keeping that in mind, which would be your investigation of choice? Serum ceruloplasmin, alpha-1 antitrypsin, serum iron, or serum ferrous levels. Remember that this Kayser-Fleischer ring is actually seen in a disease entity called as Wilson's disease, and that's what we are trying to rule out. This is happening because there is abnormal copper handling by the liver, and this copper is getting accumulated in our body. Now, this also gets accumulated in the basal ganglia in the brain, and there is associated liver cirrhosis. There can be associated splenomegaly, and this can result in involuntary movements in the patient, muscle rigidity, dystonia, dysphagia, and certain psychiatric disorders. So if you have a patient with neurological symptoms, low serum ceruloplasmin levels, and a brown ring in the perilimbal area, which is the Kayser-Fleischer ring, this is quite diagnostic of Wilson's disease. Other causes of Kayser-Fleischer ring include cholestasis, primary biliary cirrhosis, and cryptogenic cirrhosis. Again, see, there is a brown ring that has been deposited here. Now, usually this ring will start forming in the superior and the inferior part of the cornea, and gradually it will go and cover the entire cornea if the disease entity is not managed. Similarly, you can get confused with this image if you have a white ring in place of brown ring. This white ring is basically nothing but lipid deposition, and this is called as arcus senilis. If this white ring is seen in an individual less than 40 years of age, it is called as arcus juvenilis. And coming back again to the Stocker's line that I talked about, since this is also brown in color, you may get confused. Stocker's line is iron deposition right at the head of the pterygium where it is meeting the cornea. So Stocker's line, iron deposition, arcus senilis, lipid deposition, and Kayser-Fleischer ring is because of copper and seen in Wilson's disease. So here, to rule out Wilson's disease, we will do a serum ceruloplasmin level. Low serum ceruloplasmin will point towards Wilson's. The deposition of copper is happening in the peripheral part of Descemet's membrane. So you can also do a gonioscopy, because in gonioscopy, when you put your gonioscope, you can see that there will be brown pigment deposition even in the Descemet's membrane, and you can see it there. Sometimes gonioscopy can pick it even when it has not manifested on the cornea. The next question talks about the vitamin deficiency that can produce this picture. Now here look at this dry, soapy white deposit on the bulbar conjunctiva. Which vitamin deficiency can result in such a picture? Vitamin A, D, K, or C? Now, this is quite common, quite simple, and you would have read it in the pediatrics also. This is called as Bitot spots. This is a very advanced case of vitamin A deficiency where you see a plaque-like Bitot spots. Now, knowing the classification and the grading of xerophthalmia will help, because you can get similar questions related to vitamin A deficiency. So, knowing this classification will help you. So, we have XN, that is night blindness, one of the most common clinical presentations of children coming to us with vitamin A deficiency. Then, if it is not controlled at that stage, it goes on to develop conjunctival xerosis. You will have a dry looking conjunctiva which is wrinkled and shrunken, and it will look a leathery sort of an appearance. If it is not even controlled then, and it goes on further to develop Bitot spots as we are seeing here. The next stage is that of corneal xerosis. It progresses to develop a corneal ulcer. If the ulcer is less than about 1/3 of cornea, it is called as X3A. In X3B, the involvement is much more prominent. The area involved is more than 1/3 of cornea. Still, if the patient is not controlled and the disease progresses, we get corneal scarring, which is called as XS, and later on, it goes on to involve even the fundus and results in a long-standing deficiency. Although it may not be blinding, but it still quite significantly hampers the night vision of the patient. Now, xerophthalmic fundus is seen in adults, while all the prior stages are usually seen in children. The genesis of this Bitot spots is because of mixing of keratin with cornebacterium xerosis from the stratum corneum layer of conjunctiva, along with metaplastic changes in the conjunctival epithelium. So, in pathology section or in ocular pathology, you can be asked about what constitutes the Bitot spots, and that's the answer: keratin with cornebacterium xerosis plus metaplastic conjunctival epithelium. Now, why do patients get a vitamin A deficiency? Either they are not taking vitamin A, or the vitamin A that is being taken is not getting absorbed, or it is not getting stored. So, the reduced intake could be because of inadequate food supply, malnutrition, chronic alcoholism in adults, highly selective dieting, which has really become a fad these days, dysphagia, and in patients with mental illness with compromised nutrition. The impaired absorption of vitamin A would be because of diseases like Crohn's disease, celiac disease, pancreatic insufficiency, short bowel syndrome, patients with chronic diarrhea, inflammatory bowel disease, upper GI surgery, giardiasis, and A beta lipoproteinemia. And the reduced storage of vitamin A would either be because of liver disease or cystic fibrosis. So, this question can fit into your medicine, your pediatrics, pathology, and in ophthalmology. So, you need to know this. Which blood tests would help you clinch the diagnosis if it's not as clinically evident as was in the picture shown? So, you can get a serum vitamin A or a retinol done. The reference range for this test is 20 to 60 micrograms per deciliter. It may be normal due to circulating retinol levels which are being, circulated from the hepatic stores, and vitamin A deficiency related ocular symptoms develop at less than 10 micrograms per liter. Now, this is important to remember. You can also get a serum retinol binding protein done, the reference range of which is about 30 to 75 micrograms per milliliter, and serum zinc done, where the reference range is about 75 to 120 micrograms per deciliter. You need to remember the treatment of vitamin A deficiency because it can come as a community medicine question, it can come as an ophthalmology question, or it can come as a pediatrics question. For young infants less than 6 months old, 50,000 international units of vitamin A are given. For older infants from 6 to 11 months, 1 lakh international units of vitamin A are given. For children, males, 12 months or more, and females from 12 months to 12 years, and 50 years or more, the dosage is 2 lakh international units. For women between 13 to 49 years with night blindness and or bite spots, 10,000 units every day or 25 international units every week for at least 3 months. Remember, for adult women, at least 3 months. Women with active corneal lesions, 2 lakh units on days 1, 2 and 14 if you want the cornea to recover. So this is important for you to remember. So the answer to our question was vitamin A. That disease entity that was shown was bite spots, and I have provided you the relevant information about vitamin A deficiency. Going on to the next question. So here again, this is an image-based question. You have a farmer who presented with pain and discharge in his left eye. Remember, the clue here is farmer. He says he sustained an injury with a leaf few days back, and what is the finding that you see? Farmer, vegetative matter, an injury, and here we have a hypopion. So all this is leading us towards fungal keratitis. So here we are seeing a hypopion, which is deposition of the polymorphonuclear cells, and in cases of bacterial keratitis, hypopion is sterile, but in cases of fungal keratitis, hypopion has fungal hyphae. In bacterial keratitis, it is mobile, and in fungal keratitis, it is usually immobile and may be convex in shape because of the pull and the tug by the fungal hyphae. Hyphema means blood in the anterior chamber. Aqueous flare is the proteinaceous release from the polymorphonuclear cells in the aqueous, and Alzheimer's is seen in trachoma. So this image is actually showing us a hypopion, and we are basically talking about a fungal keratitis patient. A little bit more about hypopion. Now, hypo means down and pion means pus. So you have it inferiorly. If you see this image, we have a slightly convex configuration. This is rich in WBCs. It can be sterile or non-sterile, as I mentioned. In bacterial keratitis, it is sterile because it is occurring due to release of toxins and not by the actual invasion of pathogens. The hypopion can be graded as well. X0 means it's absent, +1 means it's less than 2 millimeters, 2 pluses less than 5 millimeters, and 3 pluses means 5 millimeters or more. The common conditions that result in a hypopion, definitely corneal ulcer or keratitis, Behçet's disease, in which again it is sterile, endophthalmitis, panophthalmitis, in patients with pneumococcal infections where the hypopion is more central and is hemorrhagic. There is RBC also in the hypopion, so it may have a pink hue to it. Herpetic, also hemorrhagic. So if we are talking about hemorrhagic hypopion, remember these two entities, herpes and pneumococcus. Hypopion can also be seen as an adverse reaction to some drugs like rifabutin and ranibizumab, and in patients with JIA, which is juvenile inflammatory arthritis. Hyphema, as I told you, means blood in the anterior chamber. You can get a question on hyphema. So instead of an image with a hypopion, you can get an image with hyphema. Hyphema is graded from 1 to 4, 4 being full chamber, 1 being less than the inferior margin of the pupil. So here we see corneal staining because of long-standing hyphema. Here we see an entire chamber filled with black colored blood. A long-standing hyphema can take up this color, which is quite similar to the ball number 8 on a snooker table. That is why a black hyphema is called as 8-ball hyphema. In certain special scenarios, you'll get a hypopion superiorly. So it's not actually infective or an exudation, it's nothing but oil. So in patients with retinal detachment, when we do a retinal detachment surgery and do a silicone oil tamponade, in those cases, if you have excess oil, that may come out through the pupil and float up. We know that oil is lighter than water, so the oil is going to float up. So we get an inverse hypopyon, and this inverse hypopyon, if you see it superiorly, is nothing but silicone oil. Now, a lot of you would have eaten these candy canes, quite commonly seen during Christmas time. So we have another entity, which is the candy cane hyphema, quite similar to this. There is an area of fresh bleed, then for a while everything is okay, then a fresh bleed, then it's okay, then a fresh bleed. So you have red cream stripes, and this is usually seen in leukemic patients. So the answer to our question was hypopyon. The next question talks about the most common ocular manifestation of COVID-19. Those were really the dreaded times, and we have seen the worst, and almost all subspecialties have seen their fair share of complications related to COVID-19. So the options are mucormycosis, papillary conjunctivitis, follicular conjunctivitis, and uveitis. Now, mucormycosis was not that common. It came about during, post-Delta stage. The most common ocular manifestation that we saw was the follicular conjunctivitis. Now, we know that people were using masks. Despite repeated hand washing, repeated handling of masks was unavoidable. The hands and fingers were getting contaminated, and whatever you would do to avoid rubbing your eyes, that would happen inadvertently, and that was what was transferring the virus from your fingertips to the eye and resulting in follicular conjunctivitis. The virus was attaching to the ACE2 receptors, and that was eventually leading to rhinitis, stagnant tears, and conjunctivitis. Follicular conjunctivitis was the entity that resulted as a result of hand contamination. So common ocular manifestations of COVID-19 include conjunctivitis. That was because for the increased affinity for the ACE2 enzyme, ocular inflammatory disorders, orbital cellulitis, rhinoorbital mucormycosis, 3rd, 6th, and 7th nerve palsies, cotton wool spots, retinal vascular occlusions, and acute retinal necrosis, which was because of the reactivation of the herpes virus. But having said that, still the conjunctivitis was the most common option. Going on to the next question, which of the following is not a part of keratoconus? The options were irregular astigmatism, Munson sign, Habs-Dry, and scissoring reflex. So if you see here, we are showing you irregular astigmatism. This is retinoscopy being done in a patient with keratoconus. We have a with retinoscopic reflex, against retinoscopic reflex, which looks like this, and a scissor reflex that you see here, and that's characteristic of keratoconus. This is a very characteristic Munson sign because of the conical appearance of the cornea. You can see, or when the patient is looking down, there is that conical thing that is forming on the lower lid. The cornea, it appears visibly protruded in patients with advanced keratoconus, and you can see an oil droplet sign, as you can see here on retinoscopy as well. Vogue striae can be seen. Habs striae are horizontal striae and characteristic of ophthalmos or congenital glaucoma. So the incorrect answer in this lot is Habs striae. Rest all are the findings that are seen in a patient with keratoconus. You can have Fleischer rings, which are pigmented rings in peripheral cornea from iron deposition in the basal epithelial cells, and basically what is getting deposited? That is hemosiderin. We get Vogue striae, which are thin vertical lines. Now remember, Habs and horizontal, Vogues and vertical. So H for H and V for V. So Vogue striae, thin vertical streaks, which are located in posterior corneal stroma at the level of Descemet's membrane. So you can be asked a question just similar to a previous question, that at what layer would you see Vogue striae? So we see Box dry at Descemet's membrane. We also see Kayser-Fleischer ring at Descemet's membrane. Just revising in between. So the correct answer, that the incorrect option for the keratoconus was Habs dry. Another question looked at the sequence of staining that is done clinically in a patient with dry eye. Do you do a Fluorescein first followed by Rose Bengal and Lissamine? A Rose Bengal first, Fluorescein and then Lissamine? Lissamine, Rose Bengal, Fluorescein. Now I told you one thing in the previous slide, that Rose Bengal is the most irritant of the three dyes. Now, if you put something which is very irritant right in the beginning or in the middle, it is really going to cause a lot of inconvenience to the patient and you're not able to figure out your precise findings. So, Rose Bengal in the middle, in the beginning, again in the middle, does not seem like the right choice. Revisiting the images for vital dyes for dry eye, cobalt blue filter, Fluorescein staining. Second image shows green, so it's Lissamine green, and pink, pink, pink. Here we are getting Rose Bengal. So we know which filter to use for Fluorescein, cobalt blue. Others without a filter, under white light, high illumination for Rose Bengal, low illumination for Lissamine green. Now also, when you are talking about dry eye, you need to know how dry eye is actually addressed right from the beginning to later on. The dry eye patients have multiple comorbidities also, and there can be several factors. So you need to know which layer of the tear film is getting involved and if there is any chronic inflammatory factor which is going to make it worse. So there are certain non-invasive tests also which you can do as a marker for this. You can get a tear film breakup time done. So if the time is less than 10 seconds, it signifies dry eye. Osmolarity tests can be done, but they are a little expensive and not commonly done. You can do ocular surface staining. So 5 corneal spots, 9 conjunctival spots on the conjunctiva or on the lid margin are significantly diagnostic of dry eye. So you have to figure out, triage your questions and see whether your patient has mild, moderate or severe dry eye, whether there is an evaporative element to it or if it is an aqueous deficient dry eye. You also measure the tear meniscus height, which is right there under the slit lamp on high magnification, and see how much is the height. If it's about 0.2 millimeters, it's a mild patient with dry eye, 0.1 millimeters, moderate dry eye, and 0 millimeter of tear meniscus height points towards a severe dry eye. So coming back to our question, the most irritant thing needs to be put at the last. Therefore, the correct answer is where the Rose Bengal is the last. First, you put the Fluorescein dye, use a cobalt blue filter, look at the cornea, draw the staining pattern. The Fluorescein dye will also stain the tear film. You can measure the tear meniscus height. Then look at the conjunctiva using the Lissamine green, and then if required, if you have a lot of filamentary keratitis, if the patient has viral keratitis and you want some adjunctive information, or if the patient has very severe dry eye, then only use Rose Bengal. Next question talks of a middle-aged female who reported to ophthalmology OPD with a lesion as shown in the figure here. Now this is the upper palpebral conjunctiva with very large sago grain-like appearance, and this patient gives history of use of contact lenses. So the question was, what is your diagnosis? Now trachoma in this day and age in a young patient who is wearing contact lenses is not known of. Trachoma is now totally disappeared from the Indian ophthalmic scenario, and you will just see sequelae of trachoma in old patients who come to. Spring catarrh, which also means vernal catarrh or vernal keratoconjunctivitis, is usually seen in young children, more commonly in young males, can be seen in young females, but it doesn't really result in such large papillae. Now here the cue is contact lens. Then we have follicular conjunctivitis. Follicles give a very velvety, flat appearance of the palpebral conjunctiva, unlike here where you have a very typical cobblestone but large cobblestone kind of an appearance. Then you have an entity called as giant papillary conjunctivitis. We know cobblestones are seen in patients who have papillae. So if these papillae are large in size, which can happen if there is constant mechanical irritation on them, which is because of rubbing of the contact lens edge on them, it can result into formation of giant papillae. So my bet to this would be giant papillary conjunctivitis. So let's know a little bit more about giant papillary conjunctivitis. It's quite commonly seen in patients who use soft contact lenses, although on face value it would seem that hard contact lenses are more likely to rub along the palpebral conjunctiva and result in conjunctival irritation, but that's not the case. They are more commonly seen with soft contact lenses, or if there are any exposed sutures, or if the patient is wearing an artificial eye or an ocular prosthesis. They lead to redness, severe itching, mucoid discharge, and if you rubbing makes it even worse, because when they rub, there is more release of inflammatory chemokines and the cycle doesn't just take a break. If abnormally large papillae are seen, so the drops are usually unlikely to help. These are more than 0.3 millimeters in size, and there can be a hypersensitivity to the contact lens material, or if the contact lenses are old, or if the contact lens cleaning solution is old and the patient is not cleaning up their contact lens properly, it can result in giant papillary conjunctivitis. So there are several stages to it. It's a good idea to understand which stage you are dealing with so that you can tailor-make your treatment accordingly. Stage 1 will have no significant papillae, but there is quite a significant amount of mucus in the nasal corner of the eye. And once a patient wakes up, they will find in the morning that there's so much of mucus which is sitting right there in the nasal corner. And there is mild itching after they remove their lenses. Stage 2, there is an increased severity of mucus and itching. There is also mild blurring of vision towards the end of contact lens wearing time. So when they come back from office and remove their contact lenses, then they will feel more itchy and they'll feel more blurring of vision. And at this point of time, you will see small round papillae. The conjunctiva gets thickened and edematous. Stage 3 has an even further increased severity of mucus, itching, excessive lens movement when the patient blinks. And the contact lens surface also becomes coated with mucus and debris, and it really looks dirty. And here, the joint papillae, they increase in number and size, and this eventually goes on to stage 4, where there is a complete contact lens intolerance, and the contact lens becomes coated with debris and mucus, and it becomes so cloudy that it just needs to be thrown away. So again, revisiting the picture, giant sago grain-like papillae. The cue here in the question was contact lens wear. So this is a giant papillary conjunctivitis, seen more commonly in soft contact lens wearers. The next question talks about characteristic features of fungal ulcers: satellite lesions, dendritic ulcer, ring abscess, or a white hypopyon. What do you think? Before I go on to the next slide, just prep up the answer in your mind. Remember the signs of fungal corneal ulcer? We have a sterile immune ring, which is basically nothing but an immune complex which is deposited in cornea. We have a hypopyon, which is infective, convex, and immobile. And if you tell the patient to tilt their head from side to side, or you tell them to lie down and then sit and reevaluate their hypopyon, there's not going to be much change in the shape of the hypopyon. Demititious fungi lead to pigmentation, and you can get multiple satellite lesions, which are very characteristic of multiple stromal infiltration resulting from the fungal involvement of the cornea. There is significant circumciliary congestion. There are feathery margins to the ulcer. That means the margins are not really well defined. And there are several stains and culture media which can help you clinch the diagnosis of fungal keratitis. Prominent being KOH, lactophenol cotton blue, and in culture media, Sabirod's dextrose agar and Reinhardt infusion broth. So these are very characteristic for fungal keratitis. So remember these. The question can come in any form. You can be asked about stains for fungal keratitis or culture media specific for fungal keratitis. So the correct answer was satellite lesion, because dendritic ulcer is very characteristic of viral keratitis. A ring abscess is very characteristic of acanthamoeba keratitis. And if another word that is added is painful keratopathy, again very characteristic of acanthamoeba keratitis, and white hypopyon is characteristic of bacterial keratitis. So the answer of exclusion was satellite lesions, and we just saw that satellite lesions are very typical in stroma of patients with fungal keratitis. Again, we are given an image-based question. You see a cobalt blue flight with a large green stained area in the center of the cornea, and you are asked about whether this is a cobalt blue, trypan blue corneal ulcer, a cobalt green rose Bengal stain corneal opacity, a cobalt blue Fluorescein stain corneal ulcer, a cobalt blue Lissamine Green corneal ulcer. So this is a third time we got a similar question, and that really makes us think that it's very important to read the vital staining of the cornea and the conjunctiva to be able to answer any questions related to it. So we know this is blue light, so cobalt blue. We know Lissamine green stains the conjunctiva, not the cornea, and Fluorescein stains the cornea green. So the answer is C. Cobalt blue Fluorescein stained corneal ulcer. Next question talks about an image which shows diffuse congestion in the bulbar area, but there is quite prominent dilatation of episcleral blood vessels. So this is the image of the patient before and after the use of phenylephrine drops. So here the phenylephrine drops have not been put. After the drops have been put, we see that there is some amount of blanching of blood vessels. So phenylephrine drops help you to diagnose this entity. Is this episcleritis, or is it scleritis, or phylectin, or a Tenon's cyst? Let's look at the differences between episcleritis and scleritis. Episcleritis is an idiopathic inflammation, while scleritis is an autoimmune dysregulation. Episcleritis is acute in onset, has mild pain, redness and irritation. If you examine, the conjunctival vessels are mobile, they blanch with phenylephrine, and there is a reddish pinkish hue. Scleritis, on the other hand, leads to severe pain. There is pain with eye movements, there is blurred vision, the blood vessels are adherent, they do not blanch with phenylephrine, and there is a sort of bluish hue. Now remember, anything that is deeper, conjunctival vessels, episcleral vessels and scleral vessels, anything that is deeper is not exposed to the ambient oxygen, and therefore it has a little bit of component of deoxygenated blood and would appear a little darker in color. So deeper structures are darker in color, and therefore a scarlet or a bluish hue in patients with scleritis. Slit lamp may reveal nodules and scleral thinning in patients with scleritis. So the answer in our patient was episcleritis, because there was a significant blanching with phenylephrine eye drops. The next question looks at certain symptoms, and these include conjunctival redness, pharyngeal irritation, the kind I am having today, polymorphic rash, cervical lymphadenopathy, which can be seen in any of these. So what is the correct answer? Kawasaki syndrome, measles, thrombocytopenia, or mumps? Let's have a look at the symptoms of all these entities so that we land at the correct answer. Now, Kawasaki disease patients usually have a fever for greater than 5 days and 4 out of 5 symptoms. The mnemonic is CREAM, C-R-E-A-M, C for conjunctivitis, R for rash, E for edema, A for adenopathy, cervical, often unilateral, M for mucosal involvement, erythema or fissures or crusting. So fever with cream, this is Kawasaki's. Next, let's look at measles. 5 C's, coryza, cough, conjunctivitis, cranky behavior, and Kuplik spots. Now the C has been put for convenience, it's actually Koplik spots, but it will help you to remember 5 C's of measles. Mumps can be remembered by a mnemonic SOAP. S for salpingitis, O for orchitis or euphoritis, A for aseptic meningitis, and P for perittitis. Looking at what our patient had, he is a perfect fit into Kawasaki's disease, and this here is a table which looks at measles, scarlet fever and Kawasaki's disease. So the clue here was cervical lymphadenopathy, which is common with Kawasaki's disease. Patients also tend to have edema of hand and feet, which is not seen in either measles or scarlet fever. Going on to the next question, we have a 45-year-old man who presented with lagophthalmos, orbicularis oculi palsy, and loss of corneal sensations. Which of the following organisms is responsible for his condition? Mycobacterium leprae, which results in leprosy, acanthamoeba, onchocerciasis, or chlamydia tracheomatosis, or trachoma in other words. Now, the ocular manifestations of leprosy are quite common in the tuberculoid stage. You will have lagophthalmos, hyposthesia, because these microorganisms, they go via a direct route and lodge in the ciliary body, and via a neural route or an endogenous route or exogenous route, they can influence these ocular structures and result in lagophthalmos and hyposthesia, that is decreased corneal sensations. There is a damage to the sensory nerves, there is a damage to the facial nerve leading to lagophthalmos. The patients can either have inturning or an outturning of the eyelid, which is either ectropion or entropion, trichiasis, decreased corneal sensation, superficial punctate keratitis. They may also have episcleritis, scleritis or a squirrel nodule, and a very pathognomic sign, that is iris pearls. So here you can see that there are small white millet-like dots on the iris, and these patients eventually go on to develop irisotrophy and iridocyclitis. They are more likely to get cataracts, and oculomotor nerve palsy is also quite commonly seen in patients with leprosy, and more so in patients with tuberculoid leprosy. Acanthamoeba results in ring infiltrates, perineuritis, multifocal stromal infiltrates, scleritis, irisotrophy, quite painful condition seen in patients who usually go in swimming pools or in pools that are not clear or ponds which have muddy water. These patients, if untreated, can go on to develop secondary glaucoma and even chorioretinitis in some cases. Onchocerciasis fortunately is not very commonly seen in India, but it leads to conjunctival nodule formation, sclerosing keratitis, live worms in anterior chamber, complicated cataract, and chorioretinal atrophy. So it's quite common in African countries, but not so in India, and that's thankfully so. So our patient, the scenario that we were given befits Mycobacterium leprae, and therefore the answer is A. The next question looks at a 21-year-old boxer who wanted to improve his vision. Which of the following surgery is contraindicated for him? Now, usually patients who are in sports, they don't want to wear spectacles or contact lenses because of obvious reasons. So, which refractive surgery is the correct choice for them is something that needs to be seen. Now, radial keratotomy, SMILE, LASIK and PRK are the options that were given. Radial keratotomy, as the name suggests, it means that there are radial incisions on the cornea. One fist bump and these can open up the cornea like a flower. So this here on the side is a patient who got a traumatic injury, and all these incisions, they opened up because the cornea is weaker at the site of these radial incisions. So definitely radial keratotomy is a no-no. PRK is basically a surface ablation procedure. So we are ablating the corneal surface. It's more suitable for patients with thin corneas or patients who have corneal scars. It requires removal and regrowth of the epithelial cells, but it's painful and the healing process is not really very fast as you would require for sports person. So it may require a significant time off from work and activities. So I don't think this is also a good fit for this patient. Coming on to LASIK, which is basically a flap-based procedure. We lift a flap of the cornea, then the laser is provided on the stromal bed and the flap is reposited back. There is quick visual recovery. It offers a wide range of treatment. But if there is a flap, there is a chance of dislodgement of flap. Then the latest advancement is SMILE, which is actually a flapless procedure, very quick visual recovery, no requirement of a flap, requires one laser only, and there is a quick return to normal activities. So the procedure that you would not consider at all for this patient is radial keratotomy. He has a choice to choose between the other three options because everybody has to choose by their pocket, and there are other parameters also that need to be taken into consideration. But TRK, SMILE and LASIK can be considered for such individuals, and preferably so, SMILE is the best option for such patients. Going on to the next question, we have a patient who reported with diminished vision in dim light along with dry eyes and roughening of the corneal surface. Which of the following deficiencies can be associated? Iron deficiency, protein deficiency, niacin deficiency or retinoic acid deficiency. Roughening of the corneal surface, dry eyes points towards xerophthalmia, points towards corneal scarring or corneal dryness. So I think we are getting back from where we had started. That is vitamin A deficiency. So a quick revisit to what we read about: XN, night blindness; X1A, conjunctival xerosis; X1B, B for bite spots; X2, corneal xerosis; X3A, corneal ulceration less than 1/3 of the cornea; X3B, corneal ulceration more than 1/3 of the cornea; corneal scarring and xerophthalmic fundus. So serum retinols less than 0.70 micromoles per liter will lead to a subclinical vitamin A deficiency, while serum retinol levels of less than 0.05 micromoles per liter would result in a severe vitamin A deficiency. Xerophthalmia and night blindness follow if the levels are lower. So the correct answer is retinoic acid, because retinoic acid is a part of vitamin A metabolism and vitamin A cycling, and therefore retinoic A deficiency would result in corneal and conjunctival dryness. So this patient needs to be supplemented with vitamin A in the dosage that we have already talked about. Now this was what has already been asked in the previous examination. So I'm just giving you a cue to a few more options that can turn up. You have a scenario with a baby who was born at home 36 hours earlier and was brought to the neonatology department of a hospital with bilateral upper palpebral chemosis, with massive purulent secretion and pseudomembranes with no general signs of infection. And here we have markedly swollen upper lid, markedly swollen and red lower lid, and so much of purulent discharge. Now what could it be? So you can get a question on neonatal conjunctivitis. Here this question would probably talk about gonococcal conjunctivitis because there's so much of frothy discharge. So in a newborn with frothy discharge with so much of edema, you would think of ophthalmia neonatorum, which is because of gonococcus. It is usually seen 2 to 5 days after parturition. There is profuse purulent discharge with swollen eyelids. The treatment is ceftriaxone or cefotaxime. In adults, this condition is because of self-contamination, and there is also an acute onset with marked purulence. The treatment almost remains the same. Remember rule of 5 for neonatal conjunctivitis. So if the patient is presenting to you in 0 to 5 days after birth, think of gonorrhea. 5 days to 5 weeks after birth, think of chlamydia, trachomatis. 5 weeks to 5 years, streptococcus or Haemophilus influenzae are more likely to be the culprits. You can get a question which talks of long-term treatment for spring catarrh in a young boy who has now developed defective vision. Now, usually long-term treatment for severe refractory vernal catarrh or vernal keratoconjunctivitis involves use of mild dose steroids. So I think the Q is somewhere in the steroid use. So the likely options that we were given were posterior subcapsular cataract, retinopathy of prematurity, optic neuritis, and vitreous hemorrhage. So long-term steroids used for a spring catarrh include fluoromethylone or loteprednol. Usually these are milder, but in peripheral centers, there are a lot of people who use stronger steroids because they give quick relief. So by the patients themselves or by PYQs, if they are given higher potency steroids like betamethasone or dexamethasone, they are likely to develop the side effects of steroids. So they can get a steroid-induced cataract, they can get a steroid-induced glaucoma, and mostly steroid-induced cataracts are posterior subcapsular in nature. So the answer here would point towards a posterior subcapsular cataract. You can have another question where a patient comes and complains of maceration of the skin of the lids and conjunctival redness at the inner and the outer canthi. Usually when canthi are involved, we are talking of angular conjunctivitis, and the most typical agent is Moraxella or Morax Exenfield diplobacilli. So that is the correct answer. So the options can be Staph aureus, Staph viridans, Staph pneumoniae, Morax Exenfield diplobacilli, or Moraxella, either of it. Wherever you get angles and acrid or irritating discharge, where there is excoriation, there is burning of the skin, look towards Moraxella in the options, and that would be the correct answer. So we come to the end of conjunctiva and cornea MCQs. I would also suggest that you revisit our lecture on these entities in the DigiNerve section. You'll find a lot of more answers, and I wish you all the best, and I hope you crack your NEET PG and become the best doctor that you can be. Thank you.